Okay. Can we have the next speaker?
Yeah, if she rejoins, then she can finish her last part later on.
Is it open for question answers? Or we
No,
are,
I think there are speakers left. Dr. Raja Nag, I think, is the
please
So we
last
will
speaker.
take all the questions at the end of the session.
let I know, but who is the next speaker?
Dr. Raja Nag, may I please request you to present your talk?
Yes, I'm joining. With my laptop actually, and that is why it is. Can you hear me? Hello.
Yes, you are
Yeah, your
audible.
slides are visible.
Can you hear me?
Yes, you're audible.
Yes, yes, you are audible as well.
So,
Please
good evening.
start.
My topic today is in a heart failure in a subset of very old population, namely more than 80 years, and we will discuss how to treat them and what are the objectives of our treatment. So, to give you a brief background, a large burden of our elderly population are diagnosed with heart failure, and these are expected to double by the year 2030. And heart failure still remains the number one admission diagnosis in patients over 65 years of age and diagnosed in 20% of all hospitalizations. Like I said, heart failure is a huge burden on the society, the cost, and the mortality. So this is a slide showing the prevalence of heart failure by age and gender. Like you can see, the number of people living with heart failure is significantly high after the age of 65 years. And that is both in men and women. So as the treatment progresses, as science progresses, there are a large number of people who survive multiple diseases, and these are the population who age and live with heart failure. So let us come to the basics of what is heart failure. So heart failure is never a diagnosis from echo, ECG, or any other parameter, but it is a clinical diagnosis that can result from any structural or functional cardiac disorder that impairs the ability of the ventricles to fill with or eject blood. And that is very obvious from the lower three diagrams, in which the number one on your left is the normal heart. In the middle is a hypertrophied heart with impaired diastolic filling, which also constitutes heart failure. That means it fails to relax. And on your right hand side is a dilated heart, which fails to eject. So heart failure has multiple etiologies, we all know, and just to name a few, the number one cause is ischemic heart disease, hypertension, valvular heart disease, alcohol, diabetes, systemic disease, so on and so forth. So two main categories of heart failure we come across in all such patients are heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So these two categories are important because the treatment relies on the based on this diagnosis. So this is in brief echo diagram showing the pathophysiology of the heart failure with a reduced ejection fraction. It is most common in people who are younger. By younger, I mean people who are less than 65 years of age or the middle-aged with coronary artery disease. And the good thing is the heart failure with reduced ejection fraction has been studied, and a lot of therapies are available for this in the current era. But heart failure with preserved ejection fraction has not been studied as much as heart failure with reduced ejection fraction. Although 50 to 70% of patients with heart failure in various populations have heart failure with preserved ejection fraction. Now, the risk factors mainly are age. That means people who are above 60 years have mostly normal ejection fraction. Gender, 67% of elderly women with heart failure had normal ejection fraction versus only 42% with a normal ejection fraction. Hypertension and LVH are the two main comorbidities mainly found in such patients with heart failure with preserved ejection fraction. And to go into the pathophysiology of heart failure with preserved ejection fraction, these patients have impaired LV diastolic filling or relaxation. They have higher than normal filling pressures, elevated pulmonary venous pressures, impaired cardiac output due to low stroke volume, which results to fatigue and the neurohormonal activation like happens in all heart failure patients. So let us look at the major effects of cardiovascular aging. Increased systemic vascular impedance, especially in the larger arteries, leads to a higher blood pressure. This in turn leads to left ventricular hypertrophy, again, which in turn leads to reduced relaxation and compliance of the ventricles. And there also occurs diminished responsiveness to the beta adrenergic stimulation. By that, I mean there will be more need for beta blockers in such patients than the usual doses. The importance of hypertension cannot be overemphasized in such patients who have heart failure with preserved ejection fraction. And as has been seen, nearly 90% of patients with such preserved ejection fraction have hypertension. And hypertension treatment decreases the incidence of heart failure in such patients by the tune of 68%, which means that simply treating hypertension effectively and adequately in such patients can prevent heart failure with preserved ejection fraction in such patients. So these are the various trials of antihypertensive treatment on the incidence of heart failure in the elderly. Like you can see, only HIVET trial was the one which studied in patients above the age of 80 years, and the risk reduction was significant, up to 64% in such patients when hypertension was treated adequately and effectively. What are the other aggravating factors in such elderly patients? Hypertension, as I've already mentioned, renal insufficiency, anemia, thromboembolism, hyperthyroidism or hyperthyroidism, endocarditis, infections, dietary indiscretion, myocardial ischemia, underlying arrhythmias, mainly atrial fibrillation in such populations, obstructive sleep apnea, and new and worsened heart valve disease, like aortic stenosis, which occurs frequently in such elderly patients. So multimorbidity is a problem in such patients when we deal with heart failure. And these patients have multiple chronic conditions, and 90% have more than 2 such chronic conditions, and up to 60% have more than 5 such chronic conditions. Geriatric syndromes like functional and mobility impairment, impairment in the daily activities, cognitive dysfunction, Parkinsonism are all a part of this comorbid syndromes. Both are related to adverse outcomes and lead to increased mortality and morbidity. This is a busy slide, which basically shows heart failure patients have a lot of comorbidity along with because of their chronic conditions. And this was studied from this fee for service beneficiaries from the 2010 slide. So the common comorbid conditions come across in older adults with heart failure are hypertension, ischemic heart disease, atrial fibrillation is not uncommon, stroke, diabetes, dyslipidemia, COPD, CKD, anemia, osteoarthritis, or a malignancy. Geriatric comorbid conditions are present in 27% with cognitive impairment, 39% have mobility impairment, and activities of daily living impairment are also present, along with incontinence, frailty, weight loss, and visual impairment. So there is an overlap of chronic medical conditions and geriatric syndromes in such older adults with heart failure, like I have shown in my previous slides. So what are the diagnostic challenges? Dyspnea and exercise intolerance, fatigue, and weakness are common in such elderly patients. Coronary artery disease, atrial fibrillation, heart disease, COPD, obesity, pneumonia, infections, depressions are common in such patients. And these pose as a diagnostic challenge because heart failure is a clinical diagnosis and not diagnosed from either a blood marker or echo. So these patients who have normal ejection fraction will have symptoms either from heart failure or from such comorbidities like atrial fibrillation, pneumonia, obesity, etc. So these have to be distinguished clinically. So let us come to the treatment of heart failure in patients with reduced versus ejection versus preserved ejection fractions. So like I've already mentioned, reduced ejection fraction has been studied in detail with a lot of randomized control studies. We have well-defined treatment strategies. Data from large-scale randomized control trials are available, and there is substantial improvement in morbidity and mortality. On the other hand, preserved ejection fraction heart failure patients, the data are limited. Theoretic benefits of multiple agents are known. No therapy is shown to prolong life or increase the lifespan. Some data are there for reduction in hospitalizations and the symptom benefits. So the pharmacologic treatment of heart failure with reduced ejection fraction, as we all know, lies on the 4 pillars of treatment. I'll not go into the detail of that. And this is a Heart Failure Society of America practice guidelines in patients with preserved ejection fraction. Etiology affects the diagnosis, so we need to look carefully whether it is hypertension, whether it is atrial fibrillation, whether it is coronary artery disease or a valvular heart disease causing sepsis. Evaluate for ischemic heart disease, active ischemia. Aggressive BP management has to be done in such patients along with low salt diet and lifestyle changes. Diuretics for volume overload, ARBs or ACE inhibitors should be considered in such patients with multiple comorbidities. Beta blockers should be advised for patients who had prior MI or CAD with hypertension, atrial fibrillation. Calcium channel blockers for patients with atrial fibrillation if beta blockers are not enough or contraindicated, angina and hypertension. Consider rhythm control more in patients with atrial fibrillation who have new onset or are not having chronic AF, because this rhythm control, which gives the atrial kick to the cardiac output, will help in overcoming such heart failure symptoms. Enrollment in disease management program for hospitalized and high-risk patients should be done. And exercise and heart failure cannot be overemphasized. Exercise has been shown to improve diastolic function in the elderly and with more efficient relaxation of the ventricles. Regular physical activity, even in a form of 5 minutes walk, also improves exercise performance and is recommended for patients with heart failure and preserved ejection fraction. Supervised exercise has been associated with the greatest improvements. So heart failure disease management also includes this heart failure clinic care delivered in the home or to patients who are at home, because these are elderly patients we need to understand who have problems in mobility, walking, vision. So these have to be approached with a multidisciplinary team, like a nurse coordinator, clinical pharmacist, along with a cardiologist, dietitian, home health provider, and a social worker possibly. The goals are to individualize care with self-management skills and make them independent as much as possible, with increase in the compliance of intake of drugs and dietary changes, and reduce hospitalizations. So what is the evidence we have for managing such patients? Randomized trials exclude multimorbid patients. Like most of the trials exclude patients who are above the age of 80 years or who have multimorbid comorbidities. Analysis of phase 3-4 clinical trials from 5 journals, we can see that 50% excluded patients had disability, functional limitations, decreased life expectancy in the form of malignancy, cognitive impairment, non-independent living, or serious illness. So these are the patients who were excluded. So we do not have much data or evidence to support our treatment in such comorbid elderly patients who have heart failure symptoms. So the top cat excluded patients who had systolic BP more than 160, AFib, heart rate more than 90, and life expectancy less than 3 years. CHARM preserved again excluded patients who had persistent hypertension despite treatment and life expectancy less than 2 years. I preserved again with certain excluded patients who had high BP with low hemoglobin or low life expectancy. But this was the only trial, I preserved was the only trial which had a median age above 70 years or roughly 72. So RAILS trial was a beneficial trial. After that, a lot of people advised aldosterone blockers in all such patients, but which did not work in favor of such patients. I'll go fast from here because I think I've completed my time. So typical burden of an older patient with heart failure and multimorbidity has usually 4 other chronic conditions, maybe more than 4, takes 10 or more medications a day. And we need to understand that the problems they have to deal with such more number of medications. So we need to reduce the number of medications. and spends 2 hours per day on health-related activities, either going to the healthcare worker or getting someone at home, attends 15 or more outpatient appointments with physicians each year at least, and needs assistance in at least one activity of daily living, experiences hospitalization for multiple conditions and not only heart failure. These are all the best estimates made based on the available published data from America, but burden is much more in our Asian countries and more so in India. Thank you.